Hello friends, hope you're all doing good. In this video, I want to discuss with you about labor disorders. See, first we have to understand what is normal labor. See, normal labor is something where there are changes in the uterus as well as in the cervix. What's happening in the uterus? There is regular uterine contractions, right? And what is happening in the cervix? There is effacement and dilatation. So, there are some standards for this. We will discuss it shorter, but if there is any deviation from that normal standards, okay, then it is considered to be abnormal, which is known as labor disorders. Okay. So, now we will see what are the patterns for this abnormal labor patterns. Okay, repeating. Now we will see what are these abnormal labor patterns. So, abnormal labor patterns. We will go stage wise. Okay. So, first one is about the first stage. You have to know that this stage can be prolonged or it can be protracted or it can even go for a arrest. Clear? So, you have to understand that we know already that first stage can be further divided into two phases, namely latent phase and active phase. Now, let us see about latent phase first. So, when we take latent phase, the normal duration in a nulliparous woman is around 12 hours, whereas the normal duration in a multiparous woman is around 8 hours, right? Now, what is prolonged latent phase? Okay, when it is called to be a prolonged latent phase. See, just remember that this duration, when it prolongs above 20 hours, and for the multiparous woman, if it goes beyond 4 hours, then it will be known as a prolonged latent phase. Clear? Yes. And you have to know about the active phase, prolongation and arrest. Active phase, prolongation and arrest. See, here you have to understand about cervical dilatation. Okay, so that is what happening mainly here. So, in the primary gravida, dilatation should happen at a rate of 1.2 centimeter per hour, and in the multigravida, dilatation should happen at a rate of 1.5 centimeter per hour. So, for both of them, a minimum dilatation of 1.1 centimeter per hour is, 1 centimeter per hour is needed. Okay, so this is the requirement of minimal dilatation. But if this is not happening, then active phase is yet to be prolonged. In other words, even in detail, we can put it like this. Okay, so no cervical dilatation after 4 hours. Okay, when there is adequate uterine contractions and there is also rupture of the membranes. Okay. At the same time, another way of giving the definition is there is no cervical dilatation after 6 hours when there is inadequate uterine contraction or this hasn't improved even with rupturing of the membranes or oxytocin administration. Yes? Okay. Now, we will see about the second stage of labor. In second stage of labor also, there can be protraction and arrest. Okay. We will see the normal range first. For a primigravida, the second stage should be completed within 1 hour, and for a multigravida, the second stage should be completed within 30 minutes. Okay. And these stages are said to be prolonged. And we have to consider two factors for that, because in most of the second stage women will be needing epidural. So, in some cases we will be giving epidural and in some cases we won't be giving epidural. So, epidural has an effect on the duration of the labor. Okay, so that has to be considered. So, suppose there is no epidural, means for a primigravida, when it is prolonged more than 3 hours, it is called to be a prolonged second stage, and for a multigravida, if it has prolonged more than 2 hours, means then it is said to be a prolonged second stage. Clear? Suppose she has got epidural. So, epidural has been given. Then, you have to understand the fact that you will be adding additional 1 hour to the previous value. Okay. So, 3 plus 1 and 2 plus 1. Clear? So, this is how you have to remember. We will see the next stage, third stage of labor. So, what is third stage of labor? Placental separation and expulsion. So, the normal duration for this placental separation and expulsion is 30 minutes. Okay. But they say if it has crossed more than 18 minutes, then there is a likely chance of PPH. Clear? And if you see, not every woman will be taking all these 30 minutes to deliver the placenta. Mostly 90% of the women will be completing the delivery of the placenta in 10 minutes. Okay? And if you are planning to give active management of third stage of labor, it will be completed even within 5 to 6 minutes. Clear? So, what is the etiology? Okay? So, why this can happen? So, that is labor disorders can happen. Mainly, it may be related to the 3 P's of labor. Okay. So, what are the 3 P's? Power, that is nothing but the uterine contractions. Then, it is about the passenger, where it is about the abnormal position or presentation. And the next one is about the passage, that is either there can be a contracted pelvis or there can be a CPD. Clear? Now, let us see what are the risk factors. Risk factors for abnormal labor include, we have to divide it for the mother as well as the fetus. Okay. Now, let us see what are the risk factors for the mother. First one, yes, it can be advancing maternal age, or there can be gestational diabetes or hypertension, large weight gain in pregnancy, nulliparity, non-gynecoid maternal pelvis, then there can be poor hydration or nutrition. Otherwise, she can be a short-statured woman, or it can be a postpartum pregnancy. Then, during labor, already we have seen, if there is a need of epidural analgesia, there can be disturbances in the labor duration. Then, other things like infection, that is chorioamnionitis, and if there is a formation of Bandel's ring. Okay. So next we will see the risk factors in the fetus. Obviously, if there is a macrosomia, there will be labor disorders, or if there is malpresentation, or there is a non-reshoring FHR, okay, that will make us to intervene in the labor procedure, right? Then, if there is a high fetal station. We will see the pathophysiology now. See, pathophysiology of labor disorders is poorly understood. Okay. First, what was happening was, it was Friedman who was defining the stages of labor. However, one recent study that was given by another scientist and team, that is Zhang et al., was given, repeating. However, another study that came from Zhang et al., okay, has redefined the older curve. Okay. So now, when does the active phase of labor starts? See, usually most of the reference values are telling that active phase starts after 6 centimeter of dilatation. Okay. So that means latent phase is from 0 to 6 centimeters and active phase is from 7 to 10 centimeter of cervical dilatation. Clear? So we can say that there is a longer latent phase in the first stage especially. Yes, that's where we have latent and active phase, right? When there is a single factor like insufficient uterine activity, okay, that will be the most common cause of longer latent stage, and it will be mostly seen in the induced labor when compared to the spontaneous labor. Okay. And if we speak about the active phase of labor, it is not going to change in both the first and second stages, and whether it is induced or spontaneous. Clear? So there is no change whether it is first or second stage, or it is induced or spontaneous. Clear? And you have to know about the fact that regular prenatal exercise has to be encouraged. Okay? Because there are two factors. Number one, labor is a physically intensive process, right? And number two, if there is increased levels of physical activity, then there is increased levels of oxytocin released, and that will be reducing the need of induction of labor, okay, or any other intervention also. Clear? I hope you understood, right? And remember, if you take the women who are physically active and then went into labor, there is less likely chance that they have a prolonged labor. Okay, they usually don't have a prolonged labor, and especially prolongation of latent phase doesn't occur, and even there is a short active phase in them. Clear? So that's why being physically active is encouraged during pregnancy. Clear? Right. And then we'll see about the power. Power is nothing but the uterine contractions. So we know it is the uterine contractions that is going to start first, right? So uterine contractions are going to start first, that will be resulting in cervical effacement and dilatation. So how you will be assessing this uterine contractions? You have to do a abdominal examination. So this abdominal examination is a critical part of obstetric examination also. Okay, and this abdominal examination to determine the uterine activity, that is how much contractions the uterus is having, can be done in 3 methods. Number 1, you can go for a manual palpation. Number 2, you can go for an external tocodynamometer. And third option is you can go for a intrauterine pressure catheter, right? See, most of the times we'll be going for manual palpation or external tocodynamometer. Okay, if we see external tocodynamometry, what is the normal uterine activity? Okay, that means how many contractions the uterus should have. Normal reference ranges of uterine contractions include, you should get 3 to 5 contractions in 10 minutes, and remember, each of this contraction should last for 30 to 40 seconds. Clear? See, we will not be preferring intrauterine pressure catheter mostly, because when it has to be inserted to connect to the uterus through the intrauterine route, it has to be passed through the vagina and cervix, and it has to go. So, there should be ruptured membranes for this. Okay, and there are chances of infection also. So, most of the times we are not going to prefer this method. Okay, but anyhow, this is a direct measure of intrauterine activity. Okay, we'll see the different pressure ranges and when repeating. We'll see the events that are happening and the corresponding pressure ranges. Okay, so events and pressure ranges of the uterus. Okay, so number 1, uterine contractions are palpable when there is a pressure around 10 millimeter mercury. Okay, and they will become painful when the pressure rises around 15 millimeter mercury. And during the early first stage of labor, the pressure will be around 20 millimeter mercury, and during the late first stage, it can rise anywhere between 50 millimeter mercury, and in second or third stage of labor, it can rise to 100 to 120 millimeter mercury. Clear? Yes. See, this is not that much important, but even then I have given how the pressure is going to increase throughout the labor. Clear? And at this stage, I want to discuss about oxytocin also. So, if we take oxytocin, it is a key pharmacologic agent in the augmentation of uterine contractions. See, when we are administering external oxytocin, okay, pharmacological oxytocin, the response to oxytocin begins around 20 weeks of gestational age, and it will increase until 34 weeks, and after this it will remain as a plateau. Okay, and remember that oxytocin has a very short half-life. The half-life of oxytocin is around 3 to 6 minutes. So, we'll see what are the side effects. Okay, side effects of oxytocin include flushing, there can be nausea, vomiting, headache, tachycardia, maternal water retention, then there can be hyponatremia. This will happen when high oxytocin dose is given in hypotonic solutions. Clear? Then we will see about uterine tachysystole. Uterine tachysystole can occur as a result of oxytocin administration. Okay, mostly. Okay, it occurs as a result of oxytocin administration, and tachysystole means there will be 6 or more than 6 contractions in 10 minutes. Okay. See, when this much high frequency of contractions are happening in 10 minutes, what is going to happen? Whenever the uterus is contracting, it is going to compress the myometrial blood vessels. Okay. So, that time the fetal oxygenation and blood supply is going to get cut off. Right. Whenever it is relaxing, the blood flow will be regained. Okay. And there will be sufficient time to maintain the viability of the fetus. Right. But when there is a frequent contractions, contracting means there is no sufficient blood supply to the fetus and it will result in fetal deoxygenation. Clear? Now, we will see about the passenger and passage, how we are going to assess. So, the only way to assess them is digital vaginal examination. You can go and assess the passage by during a maternal pelvimetry about the bony pelvis shape and capacity you will be able to understand, and then you have to check for the cervix, that is dilatation and effacement, and then you have to know about the passenger fetus also, right? So, you have to check for the position, how is the descent, for that you have to check the station of the fetal head. Clear? Yes. See, how we are going to manage these labor disorders. See, usually when there is any abnormality in the labor progression, there can be adverse maternal and fetal outcomes as well. Okay. So, if there is a protracted or arrest of second stage of labor, you can first choose to give operative vaginal delivery using a vacuum or forceps by an experienced obstetrician, and in some cases there can be a need of cesarean section also. Suppose if there is a prolongation of third stage of labor, you have to go for manual removal of placenta. Okay. So, that is how you are going to manage. Okay. So, with this we are going to complete the labor disorders until we meet in the next video. Take care, happy learning and bye-bye.